My dear students, in this video, I am going to discuss with you about the various facets in the management of polytrauma with traumatic brain injury and followed by the consequences of massive transfusion and the limitations of treatment in compartment syndrome. So all of these findings have been rolled into a single case, and as we walk along this case, we will try to solve some of the queries that every student has during examination. So we will have to understand how to prioritize, resuscitate, protect the brain, save the limb, reconcile conflicts, and anticipate the complications in any patient who has polytrauma with traumatic brain injury. Now, how to prioritize? The prioritize is to apply the ATLS primary survey and this logic to a multisystem trauma patient to recognize the competing priorities. A patient can have injury to the abdomen, injury to the limbs, injury to the brain. So in that cases, we will have to apply the ATLS primary survey, which we all know, the airway, breathing, circulation, disabilitation, exposure. So we will have to follow that in our handling those patients. Second is resuscitate. We have to trigger and run a massive transfusion protocol as per the policies of the institute, taking into consideration the transfusion ratios and also anticipate the complications that might occur. We have to protect the brain, and in order to do that, we have to set physiological targets to avoid secondary brain injury during resuscitation. We have to save the limbs because if there is compartment syndrome, we have to recognize the evolving compartment syndrome in an obtunded polytrauma patient and decide on fasciotomy. We have to reconcile conflicts because if there is a patient with bleeding who requires permissive hypotension for hemorrhage control, vis-a-vis the requirement of cerebral perfusion due to traumatic brain injury, we have to prioritize, reconcile the conflicts and give preference to one organ, and that would be the brain. And we have to anticipate the downstream complications which are not present at particular point, but which can complicate things down the course, like coagulopathy, hyperkalemia, rhabdomyolysis, ARDS, before they occur, so that some preemptive measures can be taken. Let us come to this situation, the case template. A 28-year-old male, an unhelmeted motorcyclist, was struck by a car at a highway speed. He was found 10 feet from the bike, who was initially responsive and localizing to pain. Thereafter, he was witnessed having deformed and shortened right thigh. There was obvious external bleeding from the thigh wound, which was partially controlled at the time of transport by application of a pressure dressing by some onlookers. Patient also had distended tense abdomen, which was noticed by the rescuers who brought him to the hospital. The scene time was approximately 20 minutes. The transport time was also similar, another 20 minutes. And after the patient reached, the sister or the duty officer put a large bore IV and administered 500 ml of Ringer lactate, after which the patient is being examined by the intensivist. So there was no documented time of the last meal, allergies, medications, and patient was unable to give any telltale history. The BP was 88 by 52, heart rate was 128, saturation was 92% on room air. The GCS was E3M2V5, V2M5, GCS of score was 10, respiratory rate was 22, temperature was 35.1. So on the very first impression, the patient appears to be hypotensive, tachycardic, polytrauma patient with a reduced GCS, a likely open long bone fracture, which can be just from the deformity as bleeding, and signs also suggesting intra-abdominal hemorrhage, the swollen tense abdomen. And this is which activates the trauma system, the trauma team. So when we look into the primary survey and we have to set priorities, the first question that appears is the patient is hypoxic, hypotensive, and has a reduced GCS. So what to correct first? And the answer today is to follow the ABCD strictly sequence-wise, not severity-wise. So since sequence sets the order, so we will have to secure and optimize the airway, give high flow oxygen before treating circulation. A hypoxic hypotensive brain will suffer double injury, so we will have to administer oxygen before giving treating circulation. Reduced GCS is addressed by fixing A, B, and C first. Hypoxia and hypotension are themselves common reversible causes of falling GCS. So after this correction, the next question would be what are the immediate priorities in the first 2 minutes? So if the GCS is less than 8 or airway is threatened, definitive airway is advisable. Expose and control the external hemorrhage by direct pressure or tourniquet on the thigh if it is an out of the hospital scenario. Two large bore IVs in the emergency, sending the grouping blood for grouping and cross matching, as well as a venous blood for gases and lactate. The activation of the trauma team should follow, and also the blood bank needs to be alerted. The abdomen is distended and tense. So, what's the concern in your next step? So the concern is the ongoing intra-abdominal hemorrhage, and that can be the source of the shock. To know which, you have to go for an E-fast and look for the primary survey, look for about the presence of free fluid in the Morrison's pouch, splenorenal space, pelvis, and pneumothorax check. So that has to decide between damage control laparotomy or any further imaging that may be necessary. So the next question is why activate the massive transfusion protocol before confirming a source? The physiological signs, like this patient had a blood pressure of 88 by 52, heart rate of 128, penetrating mechanism plus positive E-fast, and that already predict a high transfusion requirement and an ABC score of more than 2, which is seen in this patient, is itself indicator that we have to confirm the source, and by the time we know the source, we have to actually activate the transfusion protocol. So waiting for a confirmed bleeding source delays, not only delays resuscitation, but it also takes away a lot of valuable time. So massive transfusion protocol activation is a clinical and anticipatory decision. It is can never be a retrospective one. So therefore, we have to activate the massive transfusion protocol before even confirming a source. Now let's look into the primary survey findings. The airway patent protecting on the own. As of now, the GCS is 10, so it is more than 8. So it is a borderline situation. The team is on standby for intubation in case airway protection becomes necessary. B for breathing. Breathing is bilaterally equal air entry. There is no tracheal deviation. Saturation is still 92% on room air with a respiratory rate of 22. Chest wall doesn't have any flail segment. Only there seems to be some areas of mild bruising. Circulation, there are cool peripheries. The capillary refill time is prolonged. It is 4 seconds. Abdomen is distended, tense, and diffusely tender. Pelvis is stable to gentle compression. Thighs are closed, deformed, shortened, and distal pulses are present, but they're faint. So the trauma team gets activated. Two large bore IVs are sited, E-fast and blood sent, and the MTPA is placed on standby. So when we have to recognize and classify shock beyond hemorrhagic shock, we have to answer certain questions. One, which class of hemorrhagic shock does this presentation fit in and why? Now, the answer to this is that this fits into the class 3 because here the blood loss is approximately 30 to 40% of the circulating volume with a heart rate of 128. The blood pressure is 88 by 52. There is narrow pulse pressure. The respiratory rate is 22 and a falling GCS. So all of this indicate decompensating shock. So the patient has moved beyond the compensated stage, which is class 1 and 2, and therefore the patient needs blood products and not just crystalloid. Then the question would be that why is excess crystalloid harmful rather than helpful? This is because large volume crystalloid dilutes clotting factors and platelets, worsens acidosis, and raises hydrostatic pressure, dislodging early clot and worsening dilutional coagulopathy. So this damage control resuscitation favors early blood products over crystalloid. using only small volumes to maintain a palpable radial pulse. The next question that would figure in this scenario is what is pervasive hypotension and when it is used. Now, deliberately targeting a lower than normal systolic blood pressure to the tune of 80 to 90 millimeter of mercury or a palpable radial pulse until bleeding is surgically controlled to avoid dislodging clot and diluting coagulation factors is what it constitutes as pervasive hypotension. It is used in penetrating or uncontrolled torso hemorrhage. Torso means abdomen in the trunk, but it is contraindicated or must be modified when there is significant traumatic brain injury or there is coexisting traumatic brain injury. So what bedside tests should be set immediately beyond the cross match? So venous or arterial blood gas with lactate and base deficit. Base deficit is best measured in the real-time markers of shock severity and resuscitation response in conjunction to them. Point of care hemoglobin, coagulation profile with fibrinogen ionized calcium, and viscoelastic testing of ROTEM if we have the facility to guide targeted blood product replacement. Now let us go to the third part of the case where the EFAST and the CT findings are available. So the EFAST reveals free fluid in the hepatorenal pouch and pelvis. There is no pericardial fluid. There is no pneumothorax. Given the hemodynamic instability along with the positive FAST, the surgical team and the intervention radiology are alerted concurrently. The CT head after brief stabilization reveals right-sided acute subdural hematoma, which is 9 millimeter thick, along with a 4 millimeter midline shift. There is effacement of the basal cisterns, but no herniation yet. There are also small contusions in the right frontal lobe. The chest CT and the abdomen pelvis shows grade 3 splenic laceration with active contrast blush. There is moderate hemoperitoneum. There is fracture of the right femoral shaft, which is comminuted and closed, and the pelvis and the chest are otherwise unremarkable. So the interpretation of these findings are there are two active surgical problems which are competing for priority. One is the intra-abdominal hemorrhage for the splenic injury, and another is the expanding subdural hematoma from the traumatic brain injury. Femur fracture is major but a non-immediately lethal because ongoing blood loss source, which is around 1 to 1.5 liters. So we will have to interpret the head injury. As I said that the head or the brain takes precedence over other organs in such scenarios. How do you classify TBI severity and where does the score of GCS-10, which this patient is having, actually fall? So by post-resuscitation GCS, we consider as mild as 13 to 15, moderate as 9 to 12, and severe as less than 8. So this patient's GCS of 10 is moderate traumatic brain injury, but a moderate traumatic brain injury with an acute subdural and a midline shift behaves clinically like a patient at high risk of rapid deterioration, and management should anticipate that. The next question would then be what CT findings here signal a risk of imminent deterioration? So midline shift disproportionate to clot thickness suggests underlying swelling or edema. Effacement of basal cisterns is an early sign of raised ICP and impending herniation. Any of these plus a falling GCS is an indication to involve neurosurgery urgently to possible evacuation and or ICP monitoring. So what are the indications for intracranial pressure monitoring? Severe TBI when the GCS is less than equal to 8 with an abnormal CT, or severe TBI with a normal CT plus any two of either age more than 40 or unilateral or bilateral posturing or systolic blood pressure of less than 90 mmHg. And in moderate TBI patient, a repeat CT and close neurological observations will guide the decision. Monitoring is considered if it requires sedation or ventilation for other injuries because serial examinations for examination of this neurological system becomes unreliable on the course of those administration. Next question will be, does the splenic injury or the subdural take the patient to the theater first? So this has to be judged jointly, not by any fixed rules as a person. And if hemodynamically stabilization is required, so damage control laparotomy or angioembolization for the spleen should proceed first or in parallel with burr-hole craniotomy, because uncontrolled hemorrhage kills faster than a stable subdural. A hybrid or combined team approach with simultaneous OR is ideal when the resources allow such a venture. Now, moving on to the next part of the discussion, if we have to avoid secondary brain injury by virtue of from this subdural hematoma, which is expanding in one area of the brain, so then also we will have to set some physiological targets like SpO2 should be greater than equal to 94 to 95%, avoid any hypoxic episode. The systolic blood pressure should be more than 100 to 110, higher than the permissive hypotension torso target, normocapnia and to be maintained and avoid hyperventilation. Normothermia, normoglycemia, etc. also have their role. And the cerebral perfusion pressure target of 60 to 70 mm Hg once the ICP is monitored is really very helpful. So what should be the immediate measures? The immediate measures should be to head up 30-degree neutral leg position and loosen the cervical collar if tight, because all this will facilitate the drainage of the venous blood to the heart. Next is sedation or analgesia to blunt the ICP surgeries, like with intubation. So these surges are very, very catastrophic, and therefore one has to take measures. Short-acting agents so that neuroexamination can be repeated after the effect wanes off. Treat seizures promptly, because consider the prophylaxis as per protocol, because this causes serious problems at times, and avoid hypotonic or dextrose containing fluids because the brain cells may swell and there can be hydrocephalus. If there are signs of herniation, one has to go for hyperosmolar therapy using either hypertonic saline or mannitol. Brief controlled hyperventilation with a target of PCO2 between 30 to 32 only as a temporizing bridge to surgery. Urgent neurosurgical evacuation, and also you have to remember that we avoid jugular venous compression. So we will have to tie the collars and the ties, etc., very loosely. Moving on to the deterioration of this patient and MTP activation over the next 15 minutes, the repeat BP shows a measure of 78/44. The heart rate moves up to 138 from 122. The lactate goes up to 5.8 millimoles per liter, and the base deficit is -9. So hemoglobin on point of care testing is 7.6, as it is down from 11.2 gram per deciliter on arrival. Patient now only withdraws to pain. Anesthesia proceeds with rapid sequence intubation for airway protection and to control ventilation before transfer to the CT. IR and the trauma surgery agree on damage control laparotomy with splenectomy given ongoing instability, and the blood bank formally activates the massive transfusion protocol. So once the MTP is activated, we have to meet certain target criteria. One, the SBP for any patient less than 90 millimeter mercury despite initial fluid. The heart rate is more than 120. The positive fast with ongoing hemorrhage. Base deficit is 6. Lactate is 4. And the ABC score of greater than equal to 2 and a shock index of more than 1. That also is an indicator of MTP activation. So deciding to activate, what are the scoring tools? What is shock index and how it is used in this case? So shock index is the ratio between the heart rate and the systolic blood pressure. The normal value ranges between 0.5 and 0.7. A value greater than 1 correlates strongly with a high transfusion requirement and mortality. So it is a simple, fast, and bedside trigger that doesn't need naps, and useful the moment vitals are known. So the next question would be, what is the ABC score, or assessment of blood consumption score? So there are 4 yes/no criteria. Each one has 1 point. That includes penetrating mechanism, systolic blood pressure less than 90, heart rate of more than 120, and a positive fast. So a score of more than 2 predicts the need for massive transfusion with reasonable sensitivity and is designed to be used before the laboratory results are available. Why activate early rather than waiting for the hemoglobin to fall? Because hemoglobin is a poor real-time marker in acute hemorrhage. It doesn't fall within the fluid shifts occur and looks falsely reassuring in the first minutes. So waiting for a low HB before activating MTP causes dangerous delay, and clinical or physiological triggers are much better than this trigger. Then who needs to be informed the moment MTP is activated? It is the blood bank or transfusion service, the trauma and the surgical team, the anesthesia, the nursing runner. So all of them needs to be activated by the massive transfusion coordinator. A clear single point of contact and a standard pack release protocol prevents delays and product wastage. So what transfusion ratio is targeted and why? Now, if you try to find out answer, we know that a balanced ratio of packed cells, FFP, and platelets, approximately 1:1:1, mimics the whole blood and limits dilutional coagulopathy, which is supported by the proper trial, which finding on the hemostasis and reduced deaths from assanguination in the first 24 hours. So what adjuncts are given alongside broad blood products? So one is Tranexa, 1 gram IV over 10 minutes and then 1 gram over 8 hours. If within 3 hours of injury, reduces the hemorrhagic death. Calcium replacement, citrate in stored blood chelates calcium. So this is required. And cryoprecipitate on fibrinogen concentrate if fibrinogen is less than 1.5 to 2. And warming of all fluids and blood products is also important. Now, how is ongoing transfusion guided, fixed ratio or targeted? Now, this always we have to start with a fixed ratio empiric packs with transition to viscoelastic guided therapy, either TEG or ROTEM, as results return to titrate the specific factor deficits, which can be fibrinogen, which can be platelets, or which can be clotting factors, rather than over transfusing by ratio alone once bleeding is controlled. So what is this lethal triad and how does the protocol prevent it? So lethal triad consists of 3 components: hypothermia, acidosis, and coagulopathy. Each worsens the others in a self-reinforcing cycle that impairs clotting. Massive transfusion protocol counters it with fluid warmers, forced blank warming, permissive hypotension to limit dilution, minimal crystalloid, and early correction of the calcium and pH. So moving on to the central conflict, that whether to give priority to the brain first or the trunk first. The dilemma is that the damage control resuscitation favors permissive hypotension to limit bleeding, while TBI management demands 100 to 110 to preserve the cerebral perfusion. Now, this patient needs both strategies in place. So in combined TBI plus hemorrhagic shock, which target wins? The brain target generally takes priority because we have to maintain a systolic blood pressure of more than equal to 100. MAP sufficient for adequate cerebral perfusion is this systolic BP, because hypotension is a proven powerful driver of secondary brain injury and worse neurological outcome. Even it means being less permissive on the torso side. The next question would be, how do you achieve a higher BP without simply flooding with crystalloids? To understand that, we know that we use blood products to raise the BP. They restore the oxygen carrying capacity and support clotting simultaneously. Vasopressors can be used as a bridge to support MAP while hemorrhage is being surgically controlled rather than over transfusing. Now, does definitive hemorrhage control change the calculations? Yes. Once the splenic bleeding is surgically controlled, the rationale for permissive hypotension disappears and resuscitation can target normal to slightly elevated BP for cerebral perfusion, which was earlier a trade-off. So what monitoring helps navigate this clinical conflict in real time? Continuous arterial line for beat-to-beat BP, capnography, and once feasible, an ICP monitor to calculate CPP trials. So targets are individualized rather than being guessed from surrogate numbers. Moving on to the post-operative course of the right legs, damage control laparotomy and splenectomy was performed. The abdomen was temporarily closed. Hemodynamics stabilized after 6 units of PRBC, 6 FFPs, 1 pooled platelets, 2 grams of Tranexa, and calcium with warm fluids. Femoral shaft fracture was stabilized with an external fixator in the same anesthetic, and the patient was transferred, sedated, and ventilated to the ICU, remained intubated for airway and brain protection, but GCS was not accessible of sedation. 6 hours later, nursing staff noted that the patient's right lower leg is tensely swollen. It is cool to touch distally, and the patient's heart rate and analgesic requirement have risen several folds despite adequate sedation depth. So the new findings would be cuff or leg is tense, shiny and swollen, which is out of proportion to fixator wound, pain on massive dorsiflexion of the toes, that is patient grimaces despite sedation, reduced sensation on the dorsum of the foot, dorsalis pedis pulse is present but weaker than the contralateral side, and the compartment feels firm to palpation compared with the left leg. So recognizing compartment syndrome is important. The question that would follow include what is compartment syndrome and why is this leg at risk? So any rise in pressure with a closed osteofascial compartment that exceeds capillary perfusion pressure causing muscle and nerve ischemias. Risk factors which are present here include high energy long bone fracture, external fixation, prolonged hypotension, and massive blood or fluid resuscitation causing tissue edema, which is a classic combination. So what are the list of the 6 Ps which are actually reliable early? So when we look into these patients, we know that pain which is disproportionate to injury and worsened by passive stage, it is there. Paresthesia, pallor, pulselessness, and poikilothermia. All of these come under the classic 6 Ps. And the most sensitive signs are pain on passive stretch, pain out of proportion and pain on passive stretch. And there are risks of irreversible damage. Why is compartment syndrome dangerous to me specifically in this patient? Because this patient is sedated, ventilated, and has a reduced conscious level from TBI. So the two most sensitive signs, that is the pain on stretch and the mast, are unreliable. Clinical suspicion must stay high on with the objective findings, which is like the tense compartment, rising analgesic or HR needs, reduced sensation, etc., prompting positive pressure measurement rather than waiting for a verbal complaint. Now, is a palpable distal pulse reassuring here? No, pulses are generally preserved until very late because systolic blood pressure normally far exceeds the compartment pressure. A palpable pulse does not rule out compartment syndrome and must never be used to defer measurement or fasciotomy when other signs are present. Now, in order to confirm the diagnosis and acting, how is intercompartmental pressure measured and what are the threshold it matters and how? Now, if you see the needle manometer or a handheld device of Stryker, they measure pressure in each of the leg's 4 compartments. An absolute pressure of more than 30 millimeter Hg is concerning, but the more decision critical value is the change in pressure or the perfusion pressure, which is the diastolic pressure, blood pressure minus the compartment pressure. Then why does this change in pressure delta P matter more than absolute pressure cutoff? Because this patient has had episodes of relative hypotension. A lower systemic BP means ischemia can occur at a lower absolute compartment pressure than the traditional 30 millimeter mercury rule. So using this as account, of his individual perfusion status than a fixed population. So, what is the definitive treatment, and is there time to observe and repeat? Emergency fasciotomy of all four compartments through two incisions should be carried out. Muscle becomes irreversibly damaged after roughly 4 to 6 hours of ischemia. With objective findings already present, this was the and in fact, this is a surgical emergency and not a watch and remeasure kind of a situation. So, any special anesthetic or coagulation consideration before fasciotomy? So, we will have to correct any residual coagulopathy and thrombocytopenia as much as feasible before the incision. And that includes recent massive transfusion. We have to ensure the depth. So, the next question that would automatically arise would be that any special anesthetic coagulation or considerations before the fasciotomy. So one has to correct any residual coagulopathy and thrombocytopenia as much as feasible, but definite fasciotomy should not be delayed for perfect correction. Let's move on to the fasciotomy and the ICU course. The compartment pressures measured post fasciotomy with an anterior compartment was 42 millimeter mercury, deep posterior was 38, diastolic at the time and the 58 millimeters. So it is 58 minus 38 is 20, which is much below the 30 millimeter mark. The emergency four compartment fasciotomy performed, muscle found dusky but contractile and viable. The wounds are left open. They are dressed with negative pressure therapy and planned for delayed closure with skin grafting. The repeat CT head at 12 hours interval is found to have a stable subdural, no new shift. Sedation is gradually weaned along with neuroobservation. Then ICP monitor is ultimately not required as the patients improved without further deterioration and extubated on day 4 with a GCS of 15 and no focal deficit. The patient was discharged to rehabilitation on day 19 and staged wound closure and physiotherapy for the leg was performed. So if you look into the data, you find that the change in pressure between the compartment and the diastolic is less than 30. The compartment released are all 4. The GCS is 15 on extubation on day 4 and the discharge to rehabilitation is on the day 19. Now, if we have to anticipate downstream complications, what metabolic complications we should be aware of or careful about, particularly following reperfusion of our fasciotomy. Now, reperfusion releases myoglobin, potassium, and acid load from the previous ischemic muscles. So there is high risk of rhabdomyolysis, there is high risk of hyperkalemia, as well as worsening metabolic acidosis. So we have to monitor the CK, potassium, renal function, and urine output very closely, and ensure also that there is good urine output with IV fluids and alkalinization as per the local protocol. The next would be what are the major risks of massive transfusion itself? The major risks include number one, TRALI, which is the most severe form of transfusion-related acute lung injury, of a mimic of ARDS, TACO, that is the transfusion-associated circulatory overload, and all of them cause pulmonary edema or ARDS, hypocalcemia and hyperkalemia from stored blood, ongoing dilutional coagulopathy if the ratios are not maintained, hypothermia, and transfusion reactions, all requiring active surveillance for the next 24 to 48 hours. Now, why is this patient at particular risk of ARDS? This is because this patient had multiple hits predisposed to ARDS, massive transfusions, direct chest and systemic trauma, sepsis from splenectomy and open wounds, and a systemic inflammatory response to major surgery. So therefore, one has to do a daily assessment of PF ratio, institute lung protective ventilation, even before clinical signs appear. What are the major, given the splenectomy, what long-term precaution is required? Now, post-splenectomy patient is at lifelong risk of overwhelming post-splenectomy infection or OPSI from encapsulated organisms. In such patients, vaccination with pneumococcal, meningococcal, HIV, once the acute phase has resolved, patient's education and consideration of prophylactic antibiotics as per local guidance are essential before discharge. So the final take-home points would be that whenever we come across a polytrauma patient who also has compartment syndrome, abdominal hemorrhage, and will be traumatic brain injury, we have to follow the sequence that saves lives. That is, the ABCD should be in the actual order followed. And when several injuries compete, treat what kills first. Also, that should be in order. Next is to trigger the massive transfusion protocol on physiology, not just labs, shock index, ABC score, and the mechanism to predict transfusion and need before the hemoglobin actually starts falling because it takes time. The brain sets the BP target when the traumatic brain injury coexists. The permissive hypotension is modified, even abandoned once significant TBI is apparent. So we have to use blood products and vasopressors and not crystalloids to hold the BP. Fourth is sedation and TBI hide compartment syndrome because pain-based signs become unreliable in an obtunded patients. We rely mostly on tense compartments, rising analgesic needs, the change in the pressures, as well as a low threshold to act. So always anticipate the second wave, which may be a coagulopathy, which may be hyperkalemia, which may be rhabdomyolysis or ARDS. So these are predictable sequelae of massive transfusion and reperfusion, and they have to be monitored before they declare themselves. Thank you so much.